And next will be the neoplastic disorders of the upper respiratory tract. We will be concentrating on the upper respiratory tract. This lecture as well as the other one, these two are very important lectures. Your respiratory tract disorders are very common. Even in this class also many of us will be having. I am having from many days, weeks even. So it's not subsiding. Allergic are there, infective are there, many things are there. So inflammatory disorders of the upper respiratory tract. We'll start. These are the objectives. So we will be discussing about rhinitis, nasal cavity, inflammation. We will be discussing about the sinusitis, tonsillitis we also discuss, pharyngitis to some extent, laryngitis. These are the things we will be discussing in detail. Some of the things we will not discuss in detail. So in detail we will discuss only those which are more and most important. And also we will take into account your objectives. So what is common cold? The person coming to the class. Nasal secretions. Body aches, slightly. Yes. So common cold, as we know, many of us every now and then have common cold. The symptoms like running nose, sneezing, sore throat, small bit of fever also sometimes. So acute infections of the upper respiratory tract are one of the most common afflictions of the humans. One of the most common. Humans, most common, as you know. Many of you might be most commonly what you have? Common cold. So this is one of the most common afflictions and frequently it manifests in the form of common cold. So acute respiratory tract infections, they manifest in the form of common cold. And most common organisms are rhinoviruses, rhinoviruses, easy to understand. Rhinoviruses, then you can have coronaviruses, influenza viruses, parainfluenza, influenza, respiratory syncytial viruses, adeno and even enteroviruses can cause respiratory tract infections. And sometimes you can have group A, beta hemolytic streptococci. Okay, this can also cause. Some other bacteria can cause, and in 40% of the cases, the cause is unknown. Even the cause is unknown, it is mostly due to the viral infections. Maybe the new viral organisms are coming. New viral organisms. No. Here comes the important thing. Coronaviruses. Anybody knows about the coronavirus? Middle East respiratory virus syndrome. Very good. MERS, which is in Saudi. So this is very important. You should know about this. Good. And anybody knows about group A, beta hemolytic streptococci? What is the importance of this?
Biogen. Streptococcus biogen. Group A.
No, he's right.
Yes.
What is the importance? Very good. So you know about, there were two things important in this slide, you know about that. So what are the clinical features?
If you slide speed.
This is respiratory syncytial virus. Respiratory syncytial virus. And what are the clinical features of common cold? As you know, nasal congestion, watery discharge may be there, sneezing, scratchy, dry throat, along with mild fever, especially in children. And most of these infections, they will come in winter months and they subside. They are self-limiting, only for a week or less, and complications sometimes can occur. It can affect the sinuses. It can go into this eustachian tube and infect the otites. This otitis media it can cause in minority of the patients. So this was about the common cold. Now we go specifically to rhinitis, sinusitis like this. First is the rhinitis. Inflammation of the mucous membrane of the nose is rhinitis. Simple. It can be acute, it can be chronic. Most of the diseases we will classify into acute and chronic. Acute we also call as common cold, flu, coryza, acute catarrh. All these names can be given. So flu mainly referring when there is influenza infections due to influenza. Chronic can be specific when we know the disease like tuberculosis, syphilis, leprosy, rhinoscleroma, sarcoidosis, and there are non-specific where we are not able to identify the organism. So simple, hypertrophic, and atrophic. The names are sufficient in this case. So this is the inflammation of nose, acute and chronic. So we'll come to the acute. Acute rhinitis. What are the predisposing factors? As many of us have. Suddenly you are exposed to cold climate, you have this common cold. You have inflammation of the nose. Exposed to draughts of air, you have this. Exposure to the dust, many people have. And sudden changes in the temperature from hot to cold. During AC, you are sitting in AC, suddenly you move out and you have this running nose and sneezing and other things. So these are some of the predisposing factors. Cold, dust, sudden changes in temperature, and exposure to draughts of air. All these things, all these predisposing factors, what they cause basically? When you suddenly change the temperature, it can result in vasoconstriction. So this vasoconstriction can lead to ischemia of the mucous membrane. This is one, okay? Vasoconstriction leading to decreased blood supply, leading to ischemia. So this will damage the mucous membrane to some extent. And also, because of mechanical effects of dust and other things, there can be damage to the cilia, which is already there. So there will be decreased mucociliary clearance. So both these factors, the ischemia and destruction to the cilia, will predispose the person to infections. And what are the infections? It can be viral, it can be bacterial, or sometimes there can be allergies also. So these are now, you have the predisposing factors, this, okay. After this, these predisposing factors damage the cilia or cause vasoconstriction. After that, there will be viral infections. So viral infection will lead to profuse more watery discharge. Okay, viral infection lead to watery discharge. Bacterial infections, as you know, these will be pus forming, so purulent discharge most of the times. And allergies will also lead to watery discharge, but here it will be profuse, more than the viral infections. Okay, so suddenly you are exposed to dust. If you are allergic to dust, suddenly you will have 5-7 episodes of sneezing, and there will be running nose, profuse watery discharge. What are the characters of these infections mostly? As you know, mostly these are seasonal. Winter months, mostly. So seasonal incidence is there. And most of these, they heal spontaneously. You need not to do anything. It's not that one sneezing, two sneezing and antibiotics. Yes, I will take some. No. Wait. Just 1-2-3 days at the most, and it will go off on its own. So they heal spontaneously without treatment. And if a person initially has a watery discharge, later on it becomes pus-like or purulent. It means there is superimposed bacterial infection. Okay? So it means initially he was having viral infection. Later on he got superimposed bacterial infection. So this was rhinitis. What are the complications? Sometimes many factors are there, host factors, like decreased immunity is there, proper diet is not there, the person is smoking, and sometimes it can lead to many complications, like rhinitis can spread. You can know, rhinitis going into pharyngitis, going into laryngitis, going into ear, otitis media, and it can go further down. It can cause pneumonias also. So these are all the complications. So it can spread to the adjacent structures. So even the upper respiratory tract infection, like rhinitis, only in the nose, can go even into the lungs, causing pneumonias. This is why sometimes we have to treat the upper respiratory tract infection. If it is, prolonging, like more than 3-4 days, so we treat it so that the person doesn't involve, the infection doesn't involve the lower respiratory tract. This is the reason. So these are the complications which can occur. So how you will differ? Anybody? How you will differentiate between the allergic and the viral or bacterial?
Bacterial
rhinitis?
you will have gas and some sputum.
Okay, good.
Viral you will have maybe more
Ah,
excessive running nose.
In allergies, we have more profuse watery discharge.
Okay.
Okay.
body symptoms.
Flushing, allergy maybe,
WBC.
more flushing or redness.
Body symptoms.
Allergic reaction.
It may or may not be there. It may or may not be there.
WBC. The bacterial
Which?
increase.
Which WBC?
Eosinophilia.
Eosinophils. Specifically. Because if neutrophils are increased, pointing more towards the
Bacteria.
bacteria. Very good.
But if we
And-
don't have differential diagnosis,
Huh?
if we don't have differential diagnosis, like in our PPL case, how we can differentiate?
If you don't have the differential diagnosis,
Or differential blood count.
differential diagnosis is always
Yeah.
there. When you get a case, you have in mind 2, 3 diagnoses. If you don't have, then you have to look for other cases. One is on the basis of WBC count. So WBC count, you will find predominance of eosinophils. This points towards the allergy. Then you have to see the profuse watery discharge from the nose. And particularly exposure to something, like exposure to cold, these pollens, exposure to dust, exposure to cold. These points. These are 2 things.
History indicates something.
History indicates. Allergic history will be important. And third is marked mucous membrane swelling and edema. If there is marked edema in the mucous, it also points towards, and particularly association with the nasal polyps. So nasal polyps are also associated with the allergies. So these are 4 or 5 things. Even if you don't have the differential leukocyte count, so eosinophils, marked fluid discharge, and marked edema of the nose and paranasal sign, and along with polyp formation. This points towards the allergies. This is one of the polyps which has been, removed from the nasal cavity. So it has epithelial lining. Below you will find the edematous connective tissue, which will be filled by numerous eosinophils. So these reddish, these are eosinophils. This is never clear, your class, this projector is never clear. So people who are taking OSP here, they are unlucky to some extent. Sometimes you may not be able to differentiate. So edematous, there is edema, there is fluid. Edematous and fluid filled spaces, these are all eosinophils, small. So these are eosinophils in the. So this is particularly happening in the allergies. So acute rhinitis may be because of viruses, maybe because of bacteria, maybe because of allergies. The chronic non-specific, where we don't know about the organism, non-specific. So what are the predisposing factors? Acute attacks of rhinitis can lead to chronic rhinitis. Acute attacks occurring. And also presence of chronic sinusitis can also lead to chronic rhinitis. Interconnected. Nasal obstruction is another cause, and repeated exposure to antigens. If a person is allergic, you expose the person repeatedly to that, it can lead to chronic rhinitis.
Doctor, but it will be followed by tolerance to this antigen. It will be followed by tolerance to this antigen, right?
Why tolerance?
Because of the excessive exposure, eventually you will, the allergic reaction will be.
How many people tolerate?
I don't know.
So what is the difference between tolerance and hypersensitivity?
In blood.
Normally you are tolerating, isn't it? Your body is tolerating yourself also. You are tolerating yourself, antigens. This is called self-tolerance. But there is called autoimmunity, when the body starts reacting against yourself. This is autoimmunity. When the body excessively reacts to outside antigens, this is hypersensitivity. But many people can later on tolerate also. But most of the people in your life, how many people you have seen they are tolerating? A person having asthma, have you seen the person getting cured over a period of time?
No.
So this, but go home and study about this. Some of the people can tolerate later on, but most of the people will undergo repeated attacks of hypersensitivity over a period of time. So chronic non-specific can be simple, hypertrophic or atrophic. We will not discuss this, sir, because the lecture is big, so I omitted this thing, only the names. Chronic specific rhinitis, where you have the organism. You have the organism now. It can be TB, syphilis, leprosy, rhinosporiodosis, rhinoscleroma and sarcoidosis. These are all the causes. We will not discuss all, we will discuss only rhinoscleroma. This is very important. So what is this rhinoscleroma? This is basically a granulomatous inflammation caused by a bacteria, gram-negative bacteria, bacilli, called Klebsiella rhinoscleromatosis. So Klebsiella rhinoscleromatis, and it can affect any part in the upper respiratory tract, like nose, which is the most common site, pharynx, laryngoscleroma or tonsiloscleroma.
Common site what?
Common site is rhino, nose,
Yes.
rhinoscleroma. This is the most common site. So it is caused by gram-negative bacilli, Klebsiella rhinoscleromatis, and it can affect many parts of the upper respiratory tract, and the primary site is nose or rhinoscleroma. It causes granulomatous inflammation. Initially, when the person gets infected by this, so there will be stages: early stage, late stage and healed stage. So early stage you will find diffuse thickening, okay, diffuse thickening of the mucous membrane of the nose, diffuse thickening. As the stages progress, what now happens? Nodular stage. So nodules, small nodules and polyps appear in the mucous membrane of the nose. This is the nodular stage. Late cases, these may ulcerate. The nodules, polyps may ulcerate. Okay? So this is the ulcerative stage. And later on, there is healed stage. You know, every inflammation is followed by healing. Healing is done by fibrous tissue. So there is excessive deposition of the fibrous tissue, which can lead to obstruction in the nose or deformities of the nasal cavity. Clear? Early diffuse thickening, followed by nodules and polyps, followed by ulceration of these, followed by healing, fibrosis. Is it clear?
Okay.
So what can be the complications now from this thing? What will
Nasal
obstruction of the nasal cavity, even destruction of the nasal cavity, ulceration is there. Brain. We'll see. Microscopic picture first, then the complication. So microscopically, what you will find? In this inflammation, there will be chronic inflammation is there. Dilatation of the blood vessels, one. Then chronic inflammatory cells. Particularly, you will have plasma cells and histiocytes. But there is one important cell which is present here, which is called mucoelic cell. Okay? This is a modified histiocyte, foamy modified histiocyte, having a whitish colored cytoplasm. And also you have Russell bodies in the plasma cells, which is nothing but the protein deposited inside the plasma cell. So these two things, Russell bodies and mucoelic cells, are important here. Dilated blood vessels and squamous metaplasia of the covering epithelium also can be there. Okay? So all the features of chronic inflammation, dilated blood vessels, chronic inflammatory cells, along with Russell body and mucoelic cells, and also squamous metaplasia of the epithelium. Where else you find Russell bodies? Intelligent people, you have to tell me, otherwise I will kill you. Immune system.
dehydrogenase deficiency.
No, you have to.
اللي قبله
Not leukemia, especially you cannot say leukemia. In the same cell. No, not leukemia. In the plasma cell. So this is the hint.
لا بالهيم ما قال.
Very important disorder is this.
Very
Okay, I will tell you one more hint. Plasma cell disorder. Which plasma cell disorder have Russell bodies?
plasma cell أو المرض. Well,
Plasmacytoma. Multiple myeloma also you can find. Huh? You know, plasma cell disorders are multiple myeloma, plasmacytomas. So there you can find these Russell bodies in these plasma cells. So these are mucolytic cells, huh? Modified macrophages, histiocytes having empty looking cytoplasm. This is rhinoscleroma. Complications, obstruction of the nose. It can obstruct the pharynx or it can deform the nose. Now we finish acute and chronic rhinitis. Acute we know viral, bacterial and allergic, most common. Then in the chronic rhinitis we discussed only the rhinoscleroma. Clear? Now we will come to chronic sinusitis. This is also one of the causes whereby the person has repeated attacks of upper respiratory infections. So many people have these sinuses which are tender. If you touch them, they are tender. And they have infective focus here in these sinuses, which doesn't go off. It remains there. They take antibiotics, they get relief to some extent, but the focus is there. So again they will have infection, again they will, it's a chronic sinusitis. Why? Because of repeated attacks of acute rhinitis and acute sinusitis. A person can have chronic sinusitis. Okay? So repeated acute attacks, acute sinusitis, acute rhinitis can lead to chronic sinusitis. And also extension of infection from a tooth can cause sinusitis. Okay? So these two things. But sinusitis sometimes can be very dangerous. You know that. You know that or not?
In infant.
We'll discuss why it is very dangerous.
In infant.
We'll not discuss. We'll discuss, you will say. Chronic sinusitis, why it can be dangerous? How many sinuses? Maxillary sinus,
Paranasal sinuses.
paranasal sinuses,
Frontal.
sphenoid sinus, so many sinuses are there.
Brain, maybe.
This is very important. So infection from the sinuses can go into the brain. So one thing is it can go into the intracranial cavity. So you don't have to take it lightly. Rhinitis you can take, but if it is sinusitis, you have to be cautious. You have to treat the patient because from the sinuses it can spread into the brain. If the brain is infected, you know, infection of the brain is very dangerous. Meningitis or encephalitis. So it can spread into the brain, intracranial cavity, or it can go into the orbits. So it can go into the orbits, it can go into the intracranial cavity. Two very important things. If there is pus collection in the sinuses, it can lead to the formation of empyema. Empyema. Or there can be mucosine if there is serious accumulation. So these direct spread of infection to orbital cavity or intraorbital structures, one complication. Direct spread to the intracranial cavity, second. And if there is hypertrophy of the mucosa, it can block the ostia. You know, sinuses drain. Okay? They drain into the nasal cavity. If these ostia, the openings are blocked, so fluid or pus will accumulate within the sinuses and can lead to sinus empyema. If it is pus or sinus mucosal, if it is mucus or serous collections. So these are the complications which can occur. But the most dreaded complication is the intracranial infection, which can spread through the sinuses. So we only discussed two slides. Chronic sinusitis due to repeated attacks of acute rhinitis or acute sinusitis and infection from the tooth, and complications are important. Into the orbit, into the brain, or can lead to the formation of empyema or mucosals. Now, inflammation of the tonsils. This is also very important. And here I think it is more common. What do you think? I think so. Because whenever I go to physician here, the first thing he will pull out a piece of wood and see my tonsils. Everybody in the primary health center, in the hospital, they will do it. So I think it is more common here. That's why they are doing it. So acute tonsillitis can be there, or it can be chronic tonsillitis. Chronic, as you know, TB, syphilis and scleroma, more common, and it can be non-specific also. Acute, most of the times, because of the beta hemolytic streptococci, acute tonsillitis. But it can be because of diphtheria also. Okay? It can be because of Vincent's angina. It can be because of agranulocytic angina. Agranulocytic angina is one. In this, what happens? There is sudden decrease in the WBC count. Agranulocytic, A. So granulocytes in the blood decrease. It is due to reactions to some drugs. A person is taking some drugs, suddenly he has, sore throat, inflammation in the mouth and other things. You might have seen, I have seen, my brother has, this episode, he took some drug and suddenly he has, swellings in the mouth, sore throat and, all the things were infected in the mouth. So this is reaction to the drug. So this is called agranulocytic angina. And when you will take the blood, there will be fall in the granulocytes, decrease in the WBC count. Vincent angina is again, it is a combination of some organisms. It causes trench mouth, inflammation of whole of the mouth along with the pharynx. It is trench mouth. It is caused by gram-negative bacilli and spirochetes. So just for your information I am telling you, because you might be confused what is Vincent. So it was discovered by the Vincent. So we call it Vincent's angina. Diphtheria, so we will discuss about the acute tonsillitis first, without going into the details of these, and here we will not discuss much. Because it's a very huge topic. You will be covering it in the ENT, inshallah, these things. Acute tonsillitis. Most commonly caused by Streptococcus hemolyticus. Common in children, and it is bilateral. Most of the times it is bilateral. 3 types are there. One is catarrhal. Catarrhal means limited to the mucous membrane. Follicular, you will have follicle formation, nodules in the tonsil. Parenchymatous, involving the whole of the tonsil. So 3 types. So catarrhal tonsillitis, limited to the mucosa of the tonsil. Unilateral or bilateral, and tonsils will be red, enlarged and edematous. Second, follicular tonsillitis. Here what happens, there is formation of the pus. It is suppurative tonsillitis basically. So formation of the pus in the crypts of the tonsil lead to the formation of small dots or follicles. So dots or follicles appear on the surface of, this is nothing, these are whitish in color. So this is the collection of pus on the tonsil, in the crypts of the tonsil. Sometimes all the follicles may fuse with one another and form a membrane over the tonsil. So you will get the membranous tonsillitis. Okay? And tonsils will be red, will be congested, will be enlarged, but here they will be dotted also in the form of follicles. So I will show you something diagram. This. So this is a tonsil, enlarged. What is this?
Pharynx.
This is uvula. Huh? So these are tonsil too. So these, follicular tonsillitis. Whitish spots on the. If they coalesce, they can form membranous tonsillitis also. So this is follicular tonsillitis. And parenchymatous tonsillitis, there is suppurative inflammation of the whole substance of the tonsils. Whole tonsil will be affected. And usually it is also bilateral. Most of the tonsillitis, they are bilateral. And what can be the complications of tonsillitis?
Spread.
Complications of tonsillitis. Very easy.
Spread infection
Spread of infection where?
to the gastrointestinal.
To the valves.
To the other parts of the respiratory tract. Yeah. That is another complication. That is very important. In fact, that is very important, most important. So one is, it can spread to the regional lymph nodes, through the lymph flow, isn't it?
Yeah.
So regional lymph nodes will be enlarged, jugulo-digastric, cervical lymph node, they will be enlarged. Second is, it can spread through the blood and cause septicemia. 2. Third, it can spread to the adjacent infection sites, like it can go into the pharynx. it can go into the ears, even to the nose, even to the sinuses. It's a continuous, it can go into the lower respiratory tract. So this is the mode of spread of the tonsillitis. Direct spread, it can go from the tonsils into the paratonsillar area and cause paratonsillar abscess, which is called quinsy. This is important. Paratonsillar abscess or quinsy. It can cause rhinitis, sinusitis, pharyngitis, laryngitis, bronchitis, otitis media, and pneumonia. Lymphatic spread going into the lymph nodes, and blood spread leading to septicemia. So these are the complications. Whenever you are asked about the complication, think of adjacent spread, local spread first. Think of the lymphatic spread. Think of the blood spread. These are the three things. Even in malignancies also, inflammation, infective, everywhere these are the roots. Even if you don't know where it will go, at least write lymphatic spread, at least write hematogenous spread, blood spread, and at least write local or adjacent spread. So I will give you at least half marks, 5 out of 10. You want more? So late complications are important. In this period, in the late complication, the patient will be free of the organism. There will be no organisms. Okay? Free of organism. Occurs after 2 to 3 weeks, and the complications are 2. One is the rheumatic fever, which involves the heart, the valves of the heart. Another is post-streptococcal glomerulonephritis, which is very, very important. Okay? So 2 things. It can affect the kidneys, it can affect the heart. And it is due to the formation of
M protein.
why it occurs.
Cross reactivity.
Cross-reacting
Immune complex by M protein.
cells or
Antibodies.
Antibodies.
cross-reacting antibodies. Because there is resemblance. No, we finished. What we finished? Tonsillitis, huh? So many ites, so you're lost. Wagner's granulomatosis. You might have discussed it in, blood vessels. Have some idea? Blood vessels. What is Wagner's granulomatosis?
We didn't read that lecture.
Vasculitis. It's a vasculitis. Isn't it? Huh? Necrotizing vasculitis. Huh? So what you will find, it affects lungs, it affects the kidneys, and it affects the vessels. Okay, 3 things. In the lungs, it causes necrotizing granulomas in the upper and the lower respiratory tract. Necrotizing granulomas. And it also causes necrotizing vasculitis of the small blood vessels. And unknown etiology, but we have, which type of antibody is there? C and K, and T neutrophilic cytoplasmic antibody. C and K. So you will get 0 now. Males more than females, because you forget everything. 40 years of age and usually affects the lungs. So what you will find, there will be ulcerative lesions in the nose, palate and pharynx, upper respiratory tract, and there will be necrotizing granulomas. Remember only necrotizing granuloma, you know what it consists of. And there will be vasculitis. So granulomas, vasculitis and ulcerative lesions. Okay, 3 things will be there. Now we will discuss, recall all the things. We discussed first rhinitis, acute rhinitis. What are the causes? 1, 2, 3.
Viral, bacterial, and allergic.
Very good. Viral, bacterial, allergic. Second, we discussed about the chronic rhinitis. We didn't discuss.
Yeah, chronic rhinitis.
What is the most important in chronic rhinitis?
Rhinoscleroma.
Rhinoscleroma. Very good. So rhinoscleroma is caused by gram-negative bacilli called Klebsiella rhinoscleromatis. And what you will find in this rhinoscleroma? It is a Russell body, mucolic cells, and it is a granulomatous inflammation, collapse. And second, we discussed the chronic sinusitis. Chronic sinusitis occurs because of
Repeated attacks of
Repeated
rhinitis
attacks.
and sinusitis.
Very good. Repeated attacks of acute sinusitis and rhinitis, and also from septic infection from the tooth. And what are the complications? Sinusitis.
Brain section.
Spread in the intracranial cavity, orbital, or
Lymphatics.
okay, or mucosal formation, or empyema. Okay. Then we discuss the tonsillitis. The tonsillitis are of 3 types: acute catarrh,
Parenchymal follicular.
follicular, and parenchymal. Catarrh, only mucous membrane; follicular,
With
due to the
dots.
formation of multiple dots or follicles; and parenchymatous involving the whole. And what are the complications?
Lymphatic spread, direct spread, or septicemia.
Direct spread, very good.
Lymphatic spread,
Lymphatic spread and
or
blood
septicemia.
spread. And late complications? Okay.
Allergic reactions.
Rheumatic heart disease and
Glomerulonephritis.
These are the late complications. No, only we have kept this acute pharyngitis only one slide. Sore throat. Most of the times it is mild. Okay, most common form. Accompanies a common cold. And you have minimal physical finding. It will go on its own. But sometimes you have severe pharyngitis. What are the causes for this? You will have marked hyperemia, more sore throat, more pain in the throat, and you will have exudates. Caused by beta hemolytic streptococci. So here you have to treat it. Macrolides you can use, azithromycin you can use, or you can use the other things like augmentin.
Penicillin.
Or adenoviruses can be there, they can be there. Coxsackie virus A can be there. It can cause vesicles and ulcers also. It is called herpangina. And Epstein-Barr virus. It causes infectious mononucleosis, which is also known as kissing disease. So spines are common. So these are the common forms commonly caused by beta hemolytic streptococci. And this is the importance of streptococcal pharyngitis with tonsillitis. Why it is important? Because it can be complicated by the development of paratonsillar abscess, which is called quinsy, and also it can lead to rheumatic fever and post-streptococcal glomerulonephritis. This is the importance, and you have to treat. If you treat it, chances are less. If you don't treat it, more chances will be there. No, only one slide and khalas. This and 2 slides are more, which are more very important from the emerging pathogens. Acute bacterial epiglottitis. Epiglottis may be infected in children, especially young children. It is caused by H. influenza, but the incidence has decreased dramatically. Why? Anybody? Because of the vaccination. Very good. Hip vaccination is there. This H. influenza vaccination, which is called hip vaccination. We give it hip HIP.
Inactivated?
Yeah. I don't know precisely, Dr. Alzar.
Okay.
I will say you inactivated or active. These are only 2 options, activated or inactive, but I don't remember properly. But I think it will be inactivated. And then, but the incidence is decreasing. Acute laryngitis, etiology, again, can be irritants, can be allergies, can be infections. But don't go into the details. One important thing here, diphtheric laryngitis. This also the incidence has decreased, again because of the vaccination, because you are continuously vaccinating the children. So, but if the person gets it, diphtheric laryngitis, what will be there? Diphtheria bacteria, it Corynebacterium diphtheriae, it elaborates a powerful exotoxin which damages the laryngeal epithelium. Powerful, very powerful exotoxin is there. So it leads to necrosis of the epithelium. So necrosis of the epithelium along with the exudate, fibrinopurulent exudate, this forms a membrane over the larynx. Okay? A dirty grey pseudomembrane. Pseudomembrane because it is not covered by the epithelium. Okay? So a pseudomembrane is formed and it can lead to many complications. Like a person can slough and there can be aspiration of these pseudomembranes or absorption of the exotoxins. Because powerful exotoxin, and it can lead to myocarditis, peripheral neuropathy, and many other things. It can go into the exotoxin, can go into many organs and damage them. So this is the importance of diphtheric laryngitis. One more important thing is there, laryngotracheobronchitis. inflammation of the larynx, trachea and bronchitis. When I was preparing the lecture, I was fitting myself somewhere in these disorders. Because I also have, from last many weeks. But what I have concluded, not from the doctors, because doctors, alhamdulillah, are very good here. They will never diagnose you. And one doctor gave me, you won't believe, he gave me augmentin. Okay. Because I told him that I have taken azithromycin, I have taken augmentin also, 7 days, I am not getting relief. He said, okay, fine. He gave me augmentin again, one. He gave me one tube, ointment type, which we have to put in the mouth and swallow it. Very difficult. Believe me, you can eat ointment or cream. It is very difficult. Even you look at the cream, you will not eat it. That contains an antibacterial and an antifungal, miconazole. And he gave me 2-3 things more also, I don't remember now. Yeah, combination treatment, every organism is covered. Organisms are covered. Whether the person will remain alive or not, that I don't know. I took it for 2 days, but I was, terrified. I had palpitations and many things. So I stopped. Then I, treated myself on my own. So alhamdulillah, I am improving now. What I thought that all the antibiotics I have tried, doctors have, seen me. Last year I had some episodes like this. So what my thinking was that it is an allergy. So I have started taking cetirizine for some days, and then I took the mast cell stabilizer, Monticulast. So no, there is an improvement, Throat is improving, and I did the Umrah also. Maybe God has, listened to me. So this was very difficult lecture for me. I was trying to fit myself into, maybe it is diphtheria or maybe it is something else, but here I am fitting. So this is combination of all, laryngotracheobronchitis. In children it can occur. In adults also it can occur, but the incidence is low. In children it is caused by parainfluenza virus. Parainfluenza virus. And it is also known as croup. Croup because of the voice. Inspiratory stridor and harsh voice is there. And persistent cough. Persistent harsh voice and cough is there. So it is but self-limited. It goes off on its own. And it can be because of allergy also. I had a group sort of a thing in the beginning because I was not able to speak properly. There was harsh voice. When I was speaking, it was barking cough, like, harsh barking cough. So I was thinking, I was having, difficulty in inspiration. But when I took these, I took puffs also in the beginning. So I had relief. So it means it is allergy, because steroids, puff, when you take, it goes off. Saudi Arabia is very good, but sometimes it is very bad. Because this Al-Juf is very dry. And believe me, it is full of dust and, dry climate. So here many of the people will be having allergies. Because a person like me never had allergy, but coming here I had these. So this is the thing which you will get. It will have inspiratory stridor, harsh persistent cough, and usually it is self-limiting. But sometimes it can complicate.
About the purulent, what's different between purulent and pus?
Purulent means pus.
Same, huh?
Yeah, same.
Okay.
Purulent means pus-like.
And about croup, it is the other name of the disease?
Croup means laryngotracheobronchitis. It is the other name of the disease. No, 3 important things are there. The last things. One is avian flu. Another is swine flu. Another is MERS. These 3 things, they were not in the list, but I thought these are important, so I put it. Avian influenza or avian flu, caused by H5N1 and H7N9. Okay, these 2. Basically, these influenza viruses are found in the birds, poultry and birds. Okay, chickens but normally they don't infect the humans. But what happens with these influenza viruses, whether they are of human origin, avian origin, animal origin, they continuously undergo some changes, which is called antigenic drift and antigenic shift. They are changing themselves. That is why we cannot make vaccines against them. When they change their structures, they can sometimes infect the humans also. They are changing their genomes basically. So they can infect the humans. So first they affect in 1997. There was a poultry outbreak in Hong Kong, but it was contained. It was contained. Then there was widespread re-emergence in 2003 and 4. And how the person get infected? From infected live or dead poultry. If he comes in contact, he will get infected. Huh? But man-to-man contact in avian flu is not well established. But if you are concerned with the poultry, definitely the person will get it. Symptoms, initially upper respiratory tract, fever, sore throat, running nose and other things, along with cough. Sometimes the patient will have other symptoms like diarrhea, vomiting, abdominal pain, chest pain, bleeding from the nose, and lower respiratory illness. Upper respiratory, GI, and goes into the lower respiratory will be, like distress, difficulty in respiration, harsh voice, and many of the patients may, die also. Pneumonia and other things may happen. So complications are hypoxemia, multiple organ failures, secondary bacterial and fungal infections. So they are a major cause. Nowadays, people are terrified because of these. So this can spread from the birds, from the poultry to the humans. These are called avian influenza. But not all the influenza viruses. So here two are important, H5N1, H7N9. And it belongs to the influenza A group. There is influenza A, influenza B, influenza C. No, second, don't concentrate on the upper one, swine flu from the pigs. Okay, H1N1 flu. So it was a pan-endemic involving many continents. Many continents. Together it was a pan, not epidemic, pan-endemic. Many continents were involved, 2009. And at least WHO reported 18,449 deaths because of this pan-endemic. Okay? And many might not be reported. This is only the figure which is, we know. But many might not be reported also. So if this much persons died, think how much might have fallen ill. Many. Many more than this. This can be transmitted from person to person. Droplet infections, inhalation or ingestion. But if pork is properly cooked, it cannot be transmitted. Properly cooked food cannot be transmitted. If poultry is properly cooked, it can also not transmit the avian influenza. So this is swine flu. Last is yours. All yours. Middle East Respiratory Syndrome, coronavirus, which is the Middle East Respiratory Syndrome coronavirus, and it causes a severe acute respiratory illness. Severe, but it mostly happens in persons who are immunocompromised, diabetics and elderly. Okay? Immunocompromised, diabetics and elderly. But it causes a very severe acute respiratory illness, fever, cough, shortness of breath, ultimately leading into the complications. Complications are more or less same in the patients and will cause at least 3 to 4 patients out of the 10 will die. I think some of the patients in Bureda also have died. Yes. I think last few days. Bureda and Qasim, many people are getting infected. So it is very near to Jove. So this figure is from the CDC America. CDC, CDC. Disease control. But now, what is the figure actually? I can't tell you precisely because it is mostly occurring in Saudi Arabia. So first case was reported in KSA in September 2012, but when they retrospectively, evaluated it, so first case was in Jordan, basically, Jordan, April 2012. And only one epidemic has been reported, or outbreak has been reported outside the Arab. It was in Korea, 2015. A person from Arab, the Korean person came to Arab, took it from here and got an outbreak there. So it was reported in Korea in 2015. So it spreads through the close contact. So it can spread to the doctors, nurses, who are caring for them. So it means too much care is also not good for the human health. Thank you so much. I hope you understood and enjoyed the class. Yes.